Anemia and Renal Disease. The Overlooked Connection, written by Julie Hord, narrated by Graziella Newson. Chapter 1, Understanding Anemia and Kidney Disease. Anemia and kidney disease are two medical conditions that frequently coexist, yet their connection is often under-recognized. Anemia, broadly defined as a reduction in the oxygen-carrying capacity of the blood due to decreased hemoglobin or red blood cell levels, is a common complication of chronic kidney disease, CKD. To fully appreciate this relationship, it is essential to understand both conditions independently and how they intersect in clinical practice. Anemia can stem from a variety of causes, including iron deficiency, chronic inflammation, blood loss, and bone marrow suppression. In the general population, it is most often associated with nutritional deficiencies or chronic diseases. In the context of kidney disease, however, anemia takes on a more complex pathophysiology. The kidneys are vital organs that, among other roles, produce erythropoietin, a hormone responsible for stimulating the bone marrow to produce red blood cells. When kidney function begins to decline, as seen in CKD, erythropoietin production diminishes, leading to a decreased red blood cell count. Chronic kidney disease is classified into 5 stages based on the estimated glomerular filtration rate, eGFR, which reflects the kidney's ability to filter waste and excess fluids from the blood. As CKD progresses from early to advanced stages, the risk and severity of anemia increase. In fact, anemia is rarely seen in early-stage CKD, but becomes significantly more prevalent in stages 3 to 5. This pattern underscores the strong correlation between declining kidney function and the onset of anemia. The relationship between anemia and renal disease is not just statistical. It has profound implications for patient outcomes. Anemia in CKD patients is associated with increased fatigue, diminished quality of life, reduced exercise capacity, and a higher risk of cardiovascular complications. Moreover, the presence of anemia often accelerates the progression of kidney disease, creating a vicious cycle that can be difficult to interrupt without timely intervention. Epidemiological studies have shown that a significant proportion of patients with moderate to severe CKD are anemic, yet many remain undiagnosed or inadequately treated. This gap in recognition and management can be attributed to the overlapping symptoms of both conditions and the complexities involved in identifying the underlying causes of anemia in renal patients. Understanding the connection between anemia and kidney disease is the first step in addressing this overlooked complication. By recognizing how the two conditions influence one another and the mechanisms that underpin their interaction, clinicians can develop more effective strategies for diagnosis, monitoring, and treatment, ultimately improving patient care and outcomes. Definitions and classifications of anemia. Anemia is a condition characterized by a deficiency in the number or quality of red blood cells, RBCs, or in the amount of hemoglobin they contain. Hemoglobin is the iron-rich protein in red blood cells responsible for transporting oxygen from the lungs to the tissues. When hemoglobin levels are insufficient, the body's tissues receive less oxygen, leading to symptoms such as fatigue, weakness, shortness of breath, and pallor. The World Health Organization defines anemia as a hemoglobin concentration of less than 13 grams per L in men and less than 12 grams in women. These thresholds may vary slightly based on age, sex, altitude, and pregnancy status, but they provide a general framework for diagnosis. Anemia is not a disease in itself, but rather a manifestation of an underlying issue. It is broadly classified based on red blood cell morphology, etiology, and pathophysiology. One of the most commonly used systems is the morphological classification, which groups anemia into 3 main types: microcytic, normocytic, and macrocytic, based on the mean corpuscular volume, MCV, of red blood cells. Microcytic anemia, characterized by small red blood cells, is most commonly associated with iron deficiency or chronic blood loss. Macrocytic anemia, where the red blood cells are larger than normal, often points to vitamin B12 or folate deficiency. Normocytic anemia, with normal-sized red blood cells, can be indicative of chronic diseases, including chronic kidney disease, CKD. From an etiological perspective, anemia can be divided into three main categories: decreased red blood cell production, increased red blood cell destruction, and blood loss. In patients with CKD, decreased production is the predominant mechanism, mainly due to reduced erythropoietin synthesis by the failing kidneys. However, other contributing factors such as inflammation, nutritional deficiencies, and blood loss from dialysis-related procedures can also play a role. The classification of anemia is critical in guiding appropriate diagnostic evaluations and management strategies. For instance, a normocytic, normochromic anemia in a patient with declining kidney function strongly suggests anemia of chronic disease or erythropoietin deficiency. However, coexisting iron or vitamin deficiencies can alter the typical presentation, underscoring the need for a comprehensive assessment. Understanding how anemia is defined and classified allows clinicians to approach patients methodically, determining the most likely causes and selecting targeted therapies. In the context of renal disease, this understanding becomes especially important as anemia is both a common and treatable complication. Timely identification and classification are key to effective intervention and improving long-term outcomes. Overview of kidney function and chronic kidney disease, CKD. The kidneys are vital organs that perform a wide range of functions essential for maintaining homeostasis in the body. Each kidney contains approximately 1 million nephrons, the functional units responsible for filtering blood and forming urine. The primary role of the kidneys is to remove metabolic waste products and excess fluids through urine formation. In addition to filtration, the kidneys regulate electrolyte balance, blood pressure, acid-base homeostasis, and red blood cell production through the secretion of erythropoietin. They also activate vitamin D, which is crucial for bone health and calcium metabolism. Chronic kidney disease, CKD, is a progressive condition characterized by the gradual loss of kidney function over time. It is typically defined by a reduction in glomerular filtration rate, GFR, or evidence of kidney damage, such as proteinuria, for 3 months or more. CKD is classified into 5 stages based on the estimated GFR, eGFR. Stage 1 represents kidney damage with normal or increased eGFR, 90 milliliters per minute, 1.73 m²², while Stage 5, also known as end-stage renal disease, ESRD, indicates severely reduced kidney function, eGFR 15 milliliters per minute, 1 m², often requiring dialysis or kidney transplantation. The most common causes of CKD include diabetes mellitus and hypertension, which together account for the majority of cases worldwide. Other contributors include glomerulonephritis, polycystic kidney disease, prolonged use of nephrotoxic drugs, and chronic urinary tract obstructions. CKD is frequently asymptomatic in its early stages, which makes it challenging to detect until significant damage has occurred. Symptoms such as fatigue, swelling, changes in urination, and anemia often appear only in more advanced stages. A hallmark complication of CKD is its systemic impact on other organ systems. The accumulation of toxins and disturbances in fluid and electrolyte balance can lead to cardiovascular disease, mineral and bone disorders, and anemia. As kidney function declines, the production of erythropoietin decreases, contributing significantly to the development of anemia in CKD patients. Moreover, reduced renal clearance of inflammatory cytokines and toxins can further suppress bone marrow function. Understanding the multifaceted role of the kidneys and the progressive nature of CKD is critical in identifying early warning signs and implementing interventions to slow disease progression. Early detection, lifestyle modifications, and proper management of underlying conditions are essential in preserving renal function and minimizing complications, such as anemia, that significantly affect patient outcomes and quality of life. Epidemiological link between anemia and renal disease. The epidemiological connection between anemia and renal disease is both significant and underappreciated. Anemia is a common complication of chronic kidney disease, CKD, with its prevalence increasing in parallel with the severity of renal dysfunction. Numerous studies have demonstrated that as kidney function declines, particularly in stages 3 through 5 of CKD, the incidence of anemia rises markedly. This correlation is not merely incidental, but reflects a pathophysiological relationship rooted in impaired erythropoietin production, chronic inflammation, iron dysregulation, and nutritional deficiencies that often accompany kidney disease. Globally, it is estimated that over 10% of the population is affected by some form of CKD. And among these individuals, anemia is present in up to 50% of those with stage 3 CKD and over 70% in those with stage 5. The prevalence is even higher in dialysis-dependent patients, many of whom experience moderate to severe anemia as a persistent condition. This global burden is particularly pronounced in low and middle-income countries, where access to early screening and treatment options may be limited, contributing to worse clinical outcomes. The link between anemia and CKD has far-reaching implications beyond just hematologic abnormalities. Epidemiological data suggests that patients with both conditions have significantly higher risks of hospitalization, cardiovascular disease, cognitive decline, and mortality. Anemia exacerbates the effects of reduced kidney function by lowering oxygen delivery to vital organs, increasing cardiac workload, and accelerating tissue hypoxia. In turn, this can hasten the progression of both CKD and its associated complications. Furthermore, untreated anemia in CKD patients is associated with decreased quality of life, reduced physical performance, and greater economic burden due to increased healthcare utilization. Several large-scale cohort studies, including data from the National Health and Nutrition Examination Survey, NANES, and various renal registries, have highlighted the prevalence and impact of anemia in CKD populations. These findings have prompted updates in clinical guidelines, encouraging earlier screening for anemia in patients with declining kidney function and more aggressive management of contributing factors such as iron deficiency and erythropoietin deficiency. Despite the wealth of epidemiological evidence, anemia in renal disease remains underdiagnosed and undertreated in many clinical settings. Part of this oversight stems from the nonspecific nature of symptoms, which can be mistakenly attributed to aging or comorbid conditions. Therefore, recognizing the epidemiological trends and clinical consequences of this dual burden is essential in optimizing patient care, guiding policy decisions, and designing effective public health strategies for early intervention. Chapter 2: Pathophysiology of Anemia and Renal Disease. The development of anemia in chronic kidney disease, CKD, is multifactorial, with its pathophysiology rooted in both the direct consequences of impaired kidney function and the systemic effects of the disease. One of the most central mechanisms involves the deficiency of erythropoietin, EPO, a glycoprotein hormone produced primarily by the peritubular fibroblasts of the renal cortex. Erythropoietin plays a critical role in stimulating the bone marrow to produce red blood cells in response to hypoxia. As kidney function declines in CKD, the damaged renal tissue becomes less responsive to hypoxic stimuli, leading to a significant reduction in EPO synthesis and consequently a drop in red blood cell production. In addition to erythropoietin deficiency, CKD is associated with a state of chronic inflammation that further contributes to anemia. Pro-inflammatory cytokines such as interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-A, are elevated in CKD and interfere with iron metabolism and erythropoiesis. These cytokines stimulate the production of hepcidin, a liver-derived hormone that inhibits iron absorption in the intestine and traps iron in storage sites within macrophages. This leads to functional iron deficiency, where iron stores may be normal or elevated, but the bioavailability of iron for red blood cell production is diminished. Uremia, another hallmark of advanced CKD, introduces a range of toxins into the bloodstream that can suppress bone marrow activity and shorten the lifespan of circulating red blood cells. These uremic toxins interfere with the proliferation and differentiation of erythroid progenitor cells and increase red cell fragility, leading to a mild yet chronic hemolytic state. Moreover, patients with CKD often experience concurrent deficiencies in essential nutrients like vitamin B12, folate, and iron due to dietary restrictions, poor appetite, or gastrointestinal losses, further complicating the picture. Hemodialysis and peritoneal dialysis, while essential for managing end-stage renal disease, can also contribute to anemia through blood loss during procedures, increased oxidative stress, and inflammation. The use of anticoagulants during dialysis and frequent blood sampling further adds to the cumulative blood loss experienced by these patients. In summary, the pathophysiology of anemia and renal disease is complex and multifaceted. It involves an interplay of hormonal deficiencies, inflammation, toxin accumulation, and nutritional imbalances. A thorough understanding of these underlying mechanisms is essential for tailoring effective treatment strategies aimed at correcting anemia, improving quality of life, and reducing the risk of adverse outcomes in CKD patients. Role of erythropoietin and renal function. Erythropoietin, EPO, is a critical hormone in the regulation of red blood cell production, and its relationship with renal function is central to understanding the development of anemia in chronic kidney disease, CKD. EPO is primarily synthesized in the peritubular interstitial cells of the renal cortex in response to decreased oxygen tension in the blood. Its main physiological role is to stimulate the bone marrow to produce erythrocytes, ensuring adequate oxygen delivery to tissues throughout the body. Under normal conditions, erythropoietin levels are finely tuned through a feedback mechanism involving oxygen-sensing cells in the kidneys. As kidney function declines in CKD, the ability of the renal tissue to detect hypoxia and generate appropriate levels of EPO is significantly impaired. The reduction in functional renal mass leads to decreased production of erythropoietin, even in the presence of anemia and tissue hypoxia. This results in a blunted erythropoietic response and contributes to the normocytic, normochromic anemia commonly observed in CKD patients. In severe cases, EPO levels may be inappropriately low or even absent, despite profound anemia. This hormonal deficiency is considered one of the primary drivers of anemia in individuals with moderate to advanced CKD. The relationship between renal function and EPO production becomes especially evident in CKD stages 3 to 5, where the majority of patients begin to develop clinically significant anemia. Unlike anemia caused by iron deficiency or acute blood loss, EPO deficiency anemia does not usually improve with iron supplementation alone, highlighting the unique pathophysiological mechanism at play. Synthetic erythropoiesis-stimulating agents, ESAs, designed to mimic the action of endogenous EPO, are commonly used in these patients to correct anemia and reduce the need for blood transfusions. Beyond its role in erythropoiesis, erythropoietin has been shown to exert cytoprotective effects on various tissues, including the heart and brain, through anti-apoptotic and anti-inflammatory pathways. These additional functions are under investigation for their potential therapeutic implications, but remain secondary to the hormone's well-established hematologic role. In conclusion, erythropoietin is a vital hormone whose production is intimately linked to renal function. The failure of the kidneys to produce adequate EPO in CKD results in a form of anemia that requires targeted treatment. Understanding this relationship underscores the importance of monitoring hemoglobin levels in patients with declining kidney function and initiating appropriate therapy when erythropoietin deficiency becomes evident. Iron homeostasis and inflammation. Iron homeostasis plays a pivotal role in erythropoiesis, and its regulation becomes significantly disrupted in the setting of chronic kidney disease, CKD. Proper iron balance is essential for hemoglobin synthesis and effective red blood cell production. However, in CKD, both absolute and functional iron deficiencies are common, largely due to the influence of chronic inflammation on iron metabolism. The interplay between iron availability and inflammation represents a critical factor in the pathophysiology of anemia and renal disease. In healthy individuals, iron is absorbed in the duodenum and jejunum and is tightly regulated by the hormone hepcidin, which is produced in the liver. Hepcidin serves as the master regulator of iron metabolism by inhibiting intestinal iron absorption and promoting the sequestration of iron within macrophages and hepatocytes. This regulation ensures that iron levels in the bloodstream remain within a safe and functional range. In CKD, hepcidin levels are often elevated due to reduced renal clearance and the persistent inflammatory state associated with kidney dysfunction. Chronic inflammation, a hallmark of CKD, stimulates the production of pro-inflammatory cytokines such as interleukin-6, IL-6, which in turn upregulate hepcidin expression. Elevated hepcidin reduces the amount of bioavailable iron, leading to a condition known as functional iron deficiency. In this state, iron stores in the body may be sufficient or even elevated, but the iron is effectively locked away and inaccessible for use in red blood cell production. This impairs the response to erythropoietin and contributes to the development and persistence of anemia. The inflammatory environment in CKD not only affects iron availability, but also impacts the bone marrow's ability to utilize iron. Inflammatory cytokines directly inhibit erythroid progenitor cells and decrease their sensitivity to erythropoietin. This further reduces the efficiency of red blood cell production, compounding the effects of iron restriction and hormonal deficiency. Managing iron homeostasis in CKD involves careful evaluation of iron status using laboratory parameters such as serum ferritin, transferrin saturation, TSAT, and newer markers like soluble transferrin receptor. However, interpreting these markers can be challenging in the presence of inflammation, as ferritin is an acute phase reactant and may not accurately reflect iron stores. In summary, the disruption of iron homeostasis in CKD is largely driven by inflammation-induced changes in hepcidin regulation. This leads to functional iron deficiency, diminished erythropoietic response, and persistent anemia. Understanding and addressing these inflammatory pathways are essential in optimizing anemia management in patients with renal disease. Uremic toxins and bone marrow suppression. Uremic toxins are metabolic waste products that accumulate in the bloodstream as kidney function declines. In healthy individuals, these substances are efficiently filtered and excreted by the kidneys. However, in chronic kidney disease, CKD, especially in advanced stages, the kidneys lose their ability to clear these toxins, leading to a state of uremia. These retained compounds not only cause systemic complications, but also have a direct and detrimental effect on hematopoiesis, contributing significantly to bone marrow suppression and the development of anemia. Among the various types of uremic toxins, middle molecules and protein-bound solutes, such as indoxyl sulfate, p-crysyl sulfate, and guanidinosuccinic acid, are particularly harmful. These substances exert toxic effects on multiple organs, including the bone marrow, where red blood cell production takes place. They interfere with the proliferation and differentiation of erythroid progenitor cells, leading to reduced erythropoiesis. Additionally, uremic toxins can induce oxidative stress and inflammation within the marrow microenvironment, further impairing its function and contributing to anemia that is resistant to standard therapies. The suppression of bone marrow activity in CKD is not limited to red blood cell production. Uremia can also impact the production of white blood cells and platelets, leading to a broader spectrum of hematological abnormalities. However, the impact on erythropoiesis is often the most clinically significant, as it directly contributes to chronic anemia and its associated complications, including fatigue, decreased physical endurance, and cardiovascular strain. Furthermore, uremic toxins have been shown to reduce the sensitivity of erythroid precursors to erythropoietin. Even when erythropoietin levels are supplemented through erythropoiesis-stimulating agents, ESAs, the response may remain suboptimal due to the toxic environment created by uremia. This phenomenon explains why some CKD patients exhibit ESA resistance, requiring higher doses to achieve target hemoglobin levels, and even then, may not experience adequate correction of anemia. Dialysis helps to remove some of these toxins, but conventional dialysis modalities are not always effective in eliminating protein-bound or larger molecular weight toxins. As a result, uremic toxin accumulation often persists, particularly in patients who are inadequately dialyzed or non-compliant with treatment regimens. In conclusion, the accumulation of uremic toxins in CKD significantly contributes to bone marrow suppression and the pathogenesis of anemia. Their direct toxic effects, coupled with inflammation and oxidative stress, hinder erythropoiesis and limit the effectiveness of conventional therapies. Understanding this relationship is crucial in developing comprehensive treatment strategies that address both the causes and consequences of anemia in renal disease. Chapter 3: Clinical Manifestations and Diagnosis. Anemia in the context of chronic kidney disease, CKD, often develops gradually, and its symptoms may be subtle or attributed to other aspects of renal dysfunction. However, as anemia progresses, it can have a profound impact on a patient's physical and cognitive functioning, quality of life, and overall prognosis. Recognizing the clinical manifestations early is essential for timely diagnosis and effective management. The most common symptoms of anemia in CKD are nonspecific and can include fatigue, weakness, pallor, shortness of breath, dizziness, and decreased exercise tolerance. These symptoms are primarily a result of reduced oxygen delivery to tissues due to a lower red blood cell count. In more severe cases, patients may experience chest pain, palpitations, and exacerbation of pre-existing cardiovascular conditions such as angina or heart failure. Cognitive impairment, depression, and poor concentration are also associated with chronic anemia and may further compromise a patient's ability to manage their illness and engage in daily activities. On physical examination, pallor of the skin and mucous membranes is often noted, particularly in more advanced cases. Tachycardia, or a systolic flow murmur, may be present due to the heart compensating for reduced oxygen carrying capacity by increasing cardiac output. In patients on dialysis, signs of volume overload may complicate the clinical picture, making the diagnosis of anemia more challenging without appropriate laboratory evaluation. The diagnosis of anemia in CKD begins with a complete blood count, CBC, which typically reveals normocytic, normochromic anemia. Hemoglobin and hematocrit levels are the primary markers used to define the severity of anemia. According to current guidelines, anemia in CKD is defined as a hemoglobin level of less than 13 grams per in men and less than 12 grams per deciliter in women. However, these thresholds may vary slightly depending on regional practices and patient characteristics. Further evaluation includes assessment of iron status through serum ferritin and transferrin saturation, TSAT, as well as markers of inflammation such as C-reactive protein CRP. Testing for vitamin B12 and folate levels may be necessary in select cases, especially when macrocytosis is observed. Measurement of erythropoietin levels is not routinely required, but may be considered when the cause of anemia is unclear or if there is suspicion of resistance to erythropoiesis-stimulating agents. In conclusion, the clinical manifestations of anemia in CKD are often subtle, but have a significant impact on patient well-being and clinical outcomes. Accurate diagnosis involves both clinical suspicion and targeted laboratory investigations, laying the foundation for effective management strategies that address the underlying causes and improve patient quality of life. Symptoms overlap and diagnostic challenges. The diagnosis of anemia in chronic kidney disease, CKD, is often complicated by the overlap of symptoms between anemia and other aspects of kidney dysfunction, as well as the presence of multiple comorbidities. This overlap makes it challenging to differentiate between anemia-related symptoms and those caused by other complications of CKD, such as fluid overload, electrolyte imbalances, or cardiovascular issues. As a result, careful clinical evaluation and a comprehensive diagnostic approach are required to ensure accurate diagnosis and appropriate management. Fatigue and weakness are among the most common and debilitating symptoms in CKD patients, and these are also the hallmark features of anemia. However, both symptoms are nonspecific and can be seen in a variety of conditions, including heart failure, depression, and sleep disturbances, which are prevalent in CKD patients. In addition, the uremic milieu of advanced CKD can cause a range of nonspecific symptoms such as malaise, anorexia, and cognitive impairment, further complicating the diagnosis of anemia. Distinguishing whether these symptoms are due to worsening renal function or anemia requires a thorough assessment, as both conditions can coexist and exacerbate one another. Another diagnostic challenge arises when patients experience fluid retention, which is common in CKD and may mask or exacerbate signs of anemia. For example, peripheral edema and pulmonary congestion can lead to shortness of breath and fatigue, symptoms that are also seen in anemia. Moreover, patients on dialysis may have difficulty differentiating between anemia-related fatigue and the fatigue caused by the dialysis process itself, particularly if they have inadequate dialysis or other complications such as infections or electrolyte disturbances. The presence of chronic inflammation in CKD adds another layer of complexity. Inflammatory cytokines are elevated in CKD and contribute to both anemia and the progression of renal disease. Elevated levels of hepcidin, an acute phase reactant, inhibit iron absorption and contribute to functional iron deficiency, which can worsen anemia. This overlap of inflammation-related anemia and iron deficiency can make it difficult to pinpoint the underlying cause of anemia in CKD patients without specific diagnostic tests. Further complicating diagnosis is the fact that anemia in CKD is often asymptomatic in the early stages, or its symptoms may be mistaken for other conditions, such as the effects of aging or other chronic diseases. In these cases, anemia may not be detected until the patient presents with more severe symptoms, requiring urgent attention. In conclusion, the overlap of symptoms between anemia and other complications of CKD, along with the presence of multiple comorbidities, presents significant diagnostic challenges. A comprehensive approach that includes a detailed clinical history, laboratory tests, and careful differentiation of overlapping symptoms is essential for accurate diagnosis and the development of effective treatment strategies. Laboratory assessment of anemia in CKD. The laboratory assessment of anemia in chronic kidney disease, CKD, is crucial for determining the underlying causes and guiding effective treatment. Given the multifactorial nature of anemia in CKD, a thorough evaluation of various parameters is necessary to differentiate between iron deficiency, erythropoietin deficiency, and other potential causes of anemia. The goal of laboratory testing is to identify the specific factors contributing to anemia in order to tailor the most appropriate therapeutic interventions. The initial step in the laboratory assessment is a complete blood count, CBC, which provides important information on hemoglobin levels, hematocrit, red blood cell count, and mean corpuscular volume, MCV. In CKD, anemia is typically normocytic and normochromic, meaning that red blood cells appear normal in size and color, but are present in reduced numbers. A hemoglobin level of less than 13 grams per Geller in men and less than 12 grams per Geller in women is generally used to define anemia in CKD. The degree of anemia is often correlated with the severity of kidney dysfunction, with more advanced stages of CKD leading to more pronounced anemia. To further assess the cause of anemia, measurements of iron status are essential. Serum ferritin, transferrin saturation, TSAT, and total iron binding capacity, TIBC, are commonly used markers. Ferritin serves as an indicator of stored iron, while TSAT reflects the availability of iron for erythropoiesis. A low TSAT, 20%, combined with low ferritin levels, 100 nanogram per milliliters, suggests absolute iron deficiency, while elevated ferritin in the presence of low TSAT indicates functional iron deficiency, which is common in CKD due to the effect of chronic inflammation and elevated hepcidin levels. In addition to iron studies, erythropoietin levels may be measured, although this is not always necessary in routine practice. Erythropoietin deficiency is a primary driver of anemia in CKD, particularly as kidney function declines. However, the level of erythropoietin does not always correlate directly with the degree of anemia, and some patients with CKD may have adequate erythropoietin levels but still experience anemia due to other factors such as inflammation or uremic toxins. Markers of inflammation, including C-reactive protein (CRP) and erythrocyte sedimentation rate (ESR), are also valuable in the laboratory assessment. Chronic inflammation, which is common in CKD, contributes to anemia by stimulating the production of hepcidin, leading to functional iron deficiency and suppression of erythropoiesis. Elevated CRP levels often correlate with worsening anemia and are indicative of an inflammatory response that can interfere with the body's ability to produce red blood cells. Finally, other causes of anemia, such as vitamin B12 and folate deficiencies, should be considered, especially if macrocytosis is present or if there is a clinical suspicion of malnutrition or malabsorption. These deficiencies can be identified through specific assays for vitamin B12 and folate levels. In conclusion, laboratory assessment of anemia in CKD involves a comprehensive approach that includes a CBC, iron studies, erythropoietin levels, and markers of inflammation. By understanding the complex interplay of these factors, clinicians can accurately diagnose the cause of anemia and implement effective treatment strategies that improve patient outcomes. Differentiating causes of anemia in renal patients. Anemia in renal patients is multifactorial, with several potential causes contributing to its development. In chronic kidney disease, CKD, distinguishing between the various causes of anemia is essential for selecting the appropriate treatment. While erythropoietin, EPO deficiency, and iron deficiency are the most common causes, other factors such as inflammation, uremic toxins, and vitamin deficiencies also play a role. Proper diagnostic evaluation is crucial in differentiating these causes, as each requires a distinct approach to management. The most common cause of anemia in CKD is erythropoietin deficiency. As kidney function declines, the production of erythropoietin, a hormone that stimulates red blood cell production, decreases. This leads to reduced erythropoiesis in the bone marrow, resulting in anemia. Erythropoietin deficiency is most pronounced in advanced stages of CKD, and it is typically diagnosed when there is a lack of appropriate erythropoietin response to anemia. However, this is not always straightforward, as some CKD patients may still have adequate levels of erythropoietin but remain anemic due to other underlying factors. Iron deficiency is another key contributor to anemia in renal patients. This can be either absolute iron deficiency, where iron stores are depleted, or functional iron deficiency, where iron is present but not available for red blood cell production due to elevated hepcidin levels associated with inflammation. Iron deficiency can occur due to blood loss, for example through dialysis or gastrointestinal bleeding, inadequate dietary intake, or impaired absorption. Laboratory tests such as ferritin, transferrin saturation, TSAT, and total iron binding capacity, TIBC, help differentiate iron deficiency from other causes. A low TSAT and ferritin level indicate iron deficiency, while a high ferritin level in the presence of a low TSAT suggests functional iron deficiency due to inflammation. Chronic inflammation is another critical factor that contributes to anemia in CKD. Inflammatory cytokines, such as interleukin-6, IL-6, stimulate the liver to produce hepcidin, which in turn inhibits iron absorption and sequestrates iron in macrophages. This leads to functional iron deficiency and suppressed erythropoiesis, even when iron stores may appear adequate on standard tests. Elevated markers of inflammation, such as C-reactive protein, CRP, help identify inflammation-related anemia, which is often difficult to treat with iron supplementation alone. Uremic toxins also play a role in anemia in CKD. These toxins accumulate due to reduced kidney function and can directly inhibit bone marrow activity. Uremic toxins suppress the production of red blood cells by interfering with erythroid progenitor cells, exacerbating anemia. Moreover, these toxins can increase oxidative stress, which further impairs red blood cell lifespan and function. Finally, deficiencies in essential nutrients such as vitamin B12 or folate can contribute to anemia, although this is less common in CKD. These deficiencies can lead to macrocytic anemia, which is distinguishable from the typical normocytic anemia seen in CKD. In conclusion, differentiating the causes of anemia in renal patients requires a comprehensive approach that includes clinical evaluation and specific laboratory tests. By understanding the underlying mechanisms, healthcare providers can more effectively treat anemia in CKD patients and improve their overall health and quality of life. Chapter 4. Iron Deficiency in CKD Patients. Iron deficiency is a common and significant cause of anemia in chronic kidney disease CKD patients. It can either be absolute, where there is insufficient iron available for erythropoiesis, or functional, where iron is present in the body but is unavailable for use in red blood cell production. Iron plays a critical role in the production of hemoglobin, the protein in red blood cells responsible for oxygen transport. In CKD, both types of iron deficiency contribute to the pathogenesis of anemia, complicating the management of this condition and requiring careful diagnostic and therapeutic approaches. Absolute iron deficiency in CKD typically arises from blood loss, which is common in this population. Blood loss can occur through hemodialysis, where patients may lose small amounts of blood with each dialysis session, or through gastrointestinal bleeding, which may be exacerbated by the use of anticoagulants or uremic platelet dysfunction. In addition, inadequate dietary intake or poor iron absorption due to gastrointestinal dysfunction can contribute to iron depletion. Absolute iron deficiency is diagnosed by measuring low serum ferritin levels, usually below 30 nanograms per milliliters, and low transferrin saturation, TSAT, levels, typically below 20%, indicating depleted iron stores. Functional iron deficiency, on the other hand, is more prevalent in CKD and is primarily due to elevated levels of hepcidin, a protein produced in the liver in response to inflammation. In CKD, inflammation is a common feature, and elevated hepcidin levels inhibit iron absorption from the gastrointestinal tract and prevent the release of stored iron from macrophages and hepatocytes. As a result, even when iron stores are adequate or elevated, the body cannot effectively mobilize iron for use in red blood cell production. Functional iron deficiency is characterized by normal or high ferritin levels with a low TSAT, which is a key diagnostic feature distinguishing it from absolute iron deficiency. The relationship between iron deficiency and anemia in CKD is complex and often requires a multifaceted approach to treatment. Oral iron supplements are commonly used to address iron deficiency, but their efficacy can be limited by gastrointestinal side effects and reduced absorption, particularly in the presence of uremia. Intravenous iron therapy is often preferred in CKD patients, especially those on dialysis, as it bypasses the gastrointestinal tract and provides more reliable delivery of iron. However, careful monitoring is necessary to avoid iron overload, which can lead to complications such as tissue damage and infections. In addition to addressing iron deficiency, the management of anemia in CKD also involves the use of erythropoiesis-stimulating agents, ESAs, to stimulate red blood cell production. However, the response to ESAs can be impaired in the presence of functional iron deficiency, as iron is a necessary component for erythropoiesis. Therefore, effective treatment of anemia in CKD requires a balanced approach that includes both iron repletion and erythropoietin supplementation, along with close monitoring of iron status. In conclusion, iron deficiency, whether absolute or functional, is a critical contributor to anemia in CKD patients. Identifying the type of iron deficiency and addressing it appropriately through iron supplementation and management of underlying inflammation is essential for optimizing anemia treatment and improving patient outcomes in this population. Absolute versus functional iron deficiency. Iron deficiency is a key contributor to anemia in chronic kidney disease, CKD patients, and understanding the distinction between absolute and functional iron deficiency is critical for effective treatment. Both forms of iron deficiency can lead to inadequate iron availability for erythropoiesis, but they differ in their underlying mechanisms, diagnostic features, and treatment strategies. Recognizing these differences is essential for managing anemia in CKD patients, as each type requires a tailored approach to therapy. Absolute iron deficiency occurs when the body's iron stores are depleted and there is insufficient iron available to meet the demands of red blood cell production. This form of iron deficiency can be caused by various factors, such as blood loss, poor dietary intake, or malabsorption. In CKD patients, blood loss during hemodialysis or gastrointestinal bleeding, often related to medications or uremic platelet dysfunction, is a common cause. Absolute iron deficiency is typically diagnosed through laboratory tests that reveal low serum ferritin levels, which reflect iron storage, and low transferrin saturation, TSAT, which indicates the amount of iron available for erythropoiesis. The combination of low ferritin and low TSAT suggests that the body has insufficient iron to produce adequate numbers of red blood cells. Functional iron deficiency, on the other hand, occurs when iron is present in the body but is unavailable for use in red blood cell production. This is often the result of chronic inflammation, which is common in CKD. Inflammatory cytokines stimulate the liver to produce hepcidin, a protein that inhibits iron absorption from the gastrointestinal tract and prevents the release of stored iron from macrophages and hepatocytes. As a result, even though iron stores may appear normal or even elevated, the body cannot mobilize the iron for erythropoiesis. Functional iron deficiency is characterized by normal or high ferritin levels coupled with low TSAT, as iron is trapped in storage and not accessible for red blood cell production. The key diagnostic difference between the two forms of iron deficiency lies in the serum ferritin and TSAT levels. In absolute iron deficiency, both ferritin and TSAT are low, indicating a depletion of iron stores. In functional iron deficiency, ferritin levels are often normal or high, but TSAT is low, signaling that the available iron is not effectively utilized for erythropoiesis. Understanding this distinction is important, as treatment strategies for each type differ. For absolute iron deficiency, the primary treatment is iron supplementation, typically in the form of oral or intravenous iron. Oral iron may be effective for mild cases, but intravenous iron is often preferred in CKD patients, particularly those on dialysis, as it bypasses the gastrointestinal tract and provides more reliable delivery of iron. In contrast, functional iron deficiency requires addressing the underlying inflammation that is inhibiting iron mobilization. This may involve the use of intravenous iron combined with erythropoiesis-stimulating agents, ESAs, which help stimulate red blood cell production. In some cases, reducing inflammation through the use of anti-inflammatory agents may also be necessary to improve iron utilization. In conclusion, absolute and functional iron deficiency are two distinct mechanisms of anemia in CKD, each requiring different diagnostic approaches and treatments. Identifying the type of iron deficiency is essential for optimizing therapy, improving red blood cell production, and ultimately enhancing patient outcomes in CKD. Iron studies interpretation in renal settings. Iron studies are crucial for diagnosing and managing anemia in chronic kidney disease, CKD, patients. Given the complex nature of anemia in CKD, iron studies provide essential information about iron availability and metabolism, helping to differentiate between absolute iron deficiency and functional iron deficiency. Interpreting these studies in the context of CKD requires an understanding of how kidney dysfunction and other factors, such as inflammation and erythropoiesis-stimulating agents, ESAs, influence iron metabolism. The primary components of iron studies include serum ferritin, transferrin saturation, TSAT, and total iron binding capacity, TIBC. These tests help assess the body's iron stores, the availability of iron for red blood cell production, and the ability of transferrin to bind and transport iron. In CKD, these values can be significantly altered due to changes in iron metabolism, inflammation, and the use of dialysis or medications. Serum ferritin is the most commonly used marker of iron stores in the body. Low ferritin levels typically indicate iron deficiency, but in CKD patients, ferritin may be elevated due to chronic inflammation. Ferritin is also an acute phase reactant, meaning that its levels can rise in response to systemic inflammation, regardless of the body's actual iron stores. This makes it challenging to interpret ferritin levels in CKD, as an elevated ferritin may indicate functional iron deficiency rather than absolute iron deficiency. Therefore, ferritin levels should always be interpreted alongside other markers such as TSAT and clinical signs of anemia. Transferrin saturation, TSAT, is a more specific indicator of iron availability for erythropoiesis. TSAT is calculated by dividing the serum iron level by the TIBC. In healthy individuals, TSAT is typically between 20% and 50%, but in CKD patients, low TSAT levels, 20%, suggest that the available iron is insufficient for optimal red blood cell production. A low TSAT combined with elevated ferritin levels is characteristic of functional iron deficiency, which is common in CKD due to elevated hepcidin levels resulting from chronic inflammation. In contrast, low ferritin and low TSAT levels point to absolute iron deficiency, where there is a true lack of available iron for erythropoiesis. Total iron binding capacity, TIBC, measures the amount of transferrin available to bind iron. In CKD patients, TIBC can be low due to increased levels of ferritin or inflammation, which alter transferrin production. A low TIBC, when seen alongside low ferritin and low TSAT, may suggest anemia related to other causes, such as uremic toxins or bone marrow suppression, rather than iron deficiency. It is important to note that iron studies in CKD patients can be confounded by the use of intravenous iron supplementation and erythropoiesis-stimulating agents, ESAs. Intravenous iron can cause transient elevations in ferritin, while ESAs can influence the body's iron needs. These treatments can mask or alter the interpretation of iron studies, making it essential for healthcare providers to consider the patient's clinical status and treatment history when interpreting the results. In conclusion, iron studies are a valuable tool for managing anemia in CKD, but their interpretation requires careful consideration of the patient's underlying kidney function, inflammation status, and treatment regimen. By understanding how various factors influence iron metabolism in CKD, clinicians can more accurately diagnose iron deficiency and implement effective treatment strategies to improve patient outcomes. Iron supplementation, oral versus intravenous. Iron supplementation is a cornerstone of anemia management in chronic kidney disease, CKD patients, particularly when iron deficiency is identified as a contributing factor. However, there are two main approaches to iron supplementation: oral and intravenous IV. Each method has its benefits and limitations, and the choice between the two depends on several factors, including the severity of iron deficiency, the patient's clinical condition, and their tolerance to treatment. Oral iron supplementation is typically the first-line treatment for mild iron deficiency. It is inexpensive, convenient, and non-invasive. Common oral iron formulations include ferrous sulfate, ferrous gluconate, and ferrous fumarate. These preparations are absorbed in the gastrointestinal tract, where they replenish the body's iron stores. However, the effectiveness of oral iron can be limited by several factors. In CKD patients, particularly those with advanced stages of the disease or on hemodialysis, the absorption of iron can be impaired due to gastrointestinal dysfunction or reduced acid secretion. Furthermore, oral iron is often associated with gastrointestinal side effects, including nausea, constipation, and abdominal discomfort, which can lead to poor adherence to therapy. These side effects are common and can significantly reduce the patient's willingness to continue treatment. In contrast, intravenous iron supplementation is typically used when oral iron is ineffective or poorly tolerated, or when more rapid iron repletion is needed. Intravenous iron is administered directly into the bloodstream, bypassing the gastrointestinal tract and allowing for more efficient delivery of iron to the tissues. This method is especially beneficial in CKD patients who are undergoing hemodialysis, as they often have high iron demands and are at risk of blood loss, making oral supplementation less effective. IV iron formulations such as iron sucrose, ferric gluconate, and ferric carboxymaltose are administered in a clinical setting, often in outpatient dialysis centers. One of the main advantages of intravenous iron is its ability to rapidly restore iron stores with a more predictable and consistent response compared to oral iron. It also avoids the gastrointestinal side effects that can limit adherence to oral iron therapy. However, IV iron is more expensive and requires administration under medical supervision, which can be less convenient for patients. Additionally, there is a risk of iron overload with intravenous therapy, particularly when used excessively or inappropriately, which can lead to adverse effects such as tissue damage, infections, and cardiovascular complications. The decision to use oral or intravenous iron supplementation depends on the severity of iron deficiency, the patient's tolerance to oral therapy, and the presence of any contraindications. For patients with mild to moderate iron deficiency who are not on dialysis, oral iron is often sufficient and preferred due to its ease of use and lower cost. However, for patients with more severe iron deficiency, those on hemodialysis, or those who are intolerant to oral iron, intravenous iron is usually recommended. In conclusion, both oral and intravenous iron supplementation are effective methods for managing iron deficiency in CKD patients. The choice of therapy should be individualized, considering the patient's clinical condition, treatment goals, and the potential risks and benefits of each approach. By carefully selecting the appropriate form of iron supplementation, healthcare providers can optimize anemia management and improve patient outcomes in CKD. Chapter 5: Erythropoiesis-Stimulating Agents. Erythropoiesis-stimulating agents, ESAs, have revolutionized the treatment of anemia in chronic kidney disease, CKD patients, especially those in the later stages of the disease or undergoing dialysis. These agents, including apoetin alpha, darbepoetin alpha, and methoxypolyethylene glycol apoetin beta, mimic the action of erythropoietin, a hormone produced primarily by the kidneys that stimulates the production of red blood cells in the bone marrow. By stimulating erythropoiesis, ESAs help to correct the anemia commonly seen in CKD, improving patient outcomes and quality of life. Anemia in CKD is often caused by decreased erythropoietin production due to kidney dysfunction. As the kidneys lose their ability to produce sufficient erythropoietin, red blood cell production in the bone marrow slows, leading to anemia. ESAs address this deficiency by providing an exogenous source of erythropoietin, which in turn promotes the production of red blood cells. ESAs are typically used in patients with moderate to severe anemia who have CKD, especially when their hemoglobin levels are significantly low, typically less than 10 gram per deciliter. The use of ESAs has been shown to reduce the need for blood transfusions, improve exercise tolerance, and alleviate symptoms of anemia, such as fatigue and weakness, in CKD patients. Moreover, by restoring normal red blood cell levels, ESAs help to maintain adequate oxygen delivery to tissues and organs, improving overall cardiovascular health. In dialysis patients, ESAs can reduce the frequency of transfusions, which are associated with complications such as iron overload and immune sensitization. However, the use of ESAs in CKD is not without risks. One of the primary concerns is the potential for cardiovascular events, such as hypertension, stroke, and heart failure, particularly when ESAs are used to increase hemoglobin levels to normal or near normal ranges. To mitigate these risks, Guidelines generally recommend maintaining hemoglobin levels between 10 and 11 gyro per liter, rather than aiming for normal levels. Additionally, ESA treatment requires careful monitoring, including regular blood tests to assess hemoglobin levels and iron status, as ESAs may increase iron demands. If iron stores are insufficient, supplementation with iron, either orally or intravenously, may be necessary to ensure that the body has enough iron for red blood cell production. Another consideration is the potential for ESA resistance, where patients fail to respond adequately to treatment. This can occur due to various factors, including inflammation, infection, inadequate dialysis, or iron deficiency. In such cases, adjusting the dose of ESA, addressing underlying conditions, or supplementing with additional iron may be required to improve response. In conclusion, erythropoiesis-stimulating agents, ESAs, are a cornerstone in the management of anemia in CKD, improving patient well-being and reducing the need for blood transfusions. However, their use must be carefully managed to minimize risks, particularly cardiovascular events and iron deficiency. With appropriate dosing and monitoring, ESAs can significantly enhance the quality of life for CKD patients, offering an effective treatment for anemia in this population. Mechanism of action and types of ESAs. Erythropoiesis-stimulating agents, ESAs, are biologic drugs designed to stimulate red blood cell production in the bone marrow. They mimic the natural hormone erythropoietin, which is primarily produced by the kidneys in response to low oxygen levels in the blood. Erythropoietin binds to erythropoietin receptors on the surface of erythroid progenitor cells in the bone marrow, initiating a cascade of signals that promote the proliferation, differentiation, and maturation of red blood cells. In patients with chronic kidney disease, CKD, the kidneys lose their ability to produce sufficient erythropoietin, leading to anemia. ESAs compensate for this deficiency by providing an exogenous source of erythropoietin, thereby restoring red blood cell production. The mechanism of action of ESAs revolves around their binding to the erythropoietin receptor, EPOR, which is expressed on the surface of erythroid progenitor cells in the bone marrow. When the ESA binds to EPOR, it activates a signaling pathway that stimulates the proliferation and differentiation of these progenitor cells into mature red blood cells. Additionally, ESAs help prevent apoptosis, cell death, of erythroid progenitors, further enhancing the production of red blood cells. This process helps to restore the oxygen-carrying capacity of the blood and correct anemia, a hallmark of CKD. The primary types of ESAs used in clinical practice are epoetin alpha, darbepoetin alpha, and methoxypolyethylene glycol epoetin beta. These agents differ in their molecular structure, pharmacokinetics, and dosing regimens, but they all exert similar effects on erythropoiesis. Epoetin alpha is a recombinant form of human erythropoietin and was the first ESA approved for use in CKD-related anemia. It has a relatively short half-life, requiring frequent dosing, typically 3 times a week for dialysis patients. While epoetin alpha is effective in increasing hemoglobin levels, its relatively short duration of action may necessitate more frequent administration compared to other ESAs. Darbepoetin alpha is a modified form of epoetin alpha with an additional carbohydrate chain that prolongs its half-life. As a result, darbepoetin alpha can be administered less frequently, often once a week or even once every 2 weeks, making it a more convenient option for patients. Its extended half-life allows for more consistent hemoglobin control and reduces the need for frequent clinic visits or injections. Methoxypolyethylene glycol epoetin beta is another long-acting ESA that is conjugated with a polyethylene glycol, egg molecule, which further prolongs its half-life. This modification allows for dosing as infrequently as once a month, offering even greater convenience for patients. Like darbepoetin alpha, methoxypolyethylene glycol epoetin beta provides stable hemoglobin control with less frequent dosing, but it may be more expensive than other ESAs. The choice of ESA depends on several factors, including patient preference, dosing convenience, cost, and individual response to treatment. In general, long-acting ESAs like darbepoetin alpha and methoxypolyethylene glycol epoetin beta are preferred for their convenience, reducing the burden of frequent injections and improving patient adherence to treatment. In conclusion, erythropoiesis-stimulating agents are essential in managing anemia in CKD, with their mechanism of action centered on stimulating red blood cell production by mimicking erythropoietin. The main types of ESAs, epoetin alpha, darbepoetin alpha, and methoxypolyethylene glycol epoetin beta, offer various advantages in terms of dosing frequency and patient convenience. Understanding their mechanisms and differences is key to selecting the most appropriate ESA for individual patients and optimizing the management of anemia in CKD. Indications and dosing strategies. Erythropoiesis-stimulating agents are primarily used to manage anemia in patients with chronic kidney disease, CKD, particularly in those who are on dialysis or in the later stages of the disease. The indications for ESA therapy are based on the severity of anemia, the patient's clinical condition, and their response to treatment. Anemia in CKD is largely driven by a deficiency of erythropoietin production, and ESAs help to restore red blood cell production by mimicking this hormone. However, the decision to initiate ESA therapy and the appropriate dosing strategies must be carefully tailored to each patient's unique circumstances. The main indication for ESA therapy in CKD patients is the treatment of anemia, defined as a hemoglobin level of less than 10 Grs per deciliter, which is common in both dialysis and non-dialysis patients. ESA therapy is particularly important for patients with moderate to severe anemia, as it helps improve oxygen delivery to tissues, alleviates symptoms such as fatigue and weakness, and reduces the need for blood transfusions. In dialysis patients, ESAs are used to maintain hemoglobin levels within a target range, typically between 10 to 11 g per deciliter, as higher levels are associated with an increased risk of cardiovascular events, including hypertension, stroke, and heart failure. Similarly, in non-dialysis dependent CKD patients, ESA therapy may be considered when hemoglobin levels fall below 10 g per deciliter, especially when other causes of anemia, such as iron deficiency, are appropriately managed. In terms of dosing strategies, ESAs are typically administered via subcutaneous or intravenous injection, depending on the specific agent and the patient's condition. The dosing schedule and dosage vary based on the type of ESA being used, the severity of anemia, and the patient's response to treatment. For example, epoetin alpha is often administered 3 times a week for dialysis patients, whereas darbepoetin alpha, with its longer half-life, may be given once a week or even once every 2 weeks. Methoxypolyethylene glycol epoetin beta, another long-acting ESA, can be administered once a month, offering significant convenience for patients. When starting ESA therapy, it is essential to begin with a lower dose and gradually adjust it based on the patient's hemoglobin levels. The goal is to achieve a hemoglobin level within the target range, avoiding both under- and overcorrection. Rapid increases in hemoglobin should be avoided, as this has been associated with adverse outcomes, such as cardiovascular events and increased mortality. Monitoring is crucial during ESA therapy, with regular checks of hemoglobin levels, iron status, and any potential side effects. If the hemoglobin level rises too quickly or exceeds the target, the dose of the ESA should be reduced. Similarly, if the response to ESA therapy is inadequate, the dose may need to be increased. In addition to the ESA dose, iron supplementation is often required to optimize treatment. Since ESAs stimulate red blood cell production, they also increase the body's need for iron. Iron deficiency, either absolute or functional, can impair the response to ESA therapy. Therefore, iron levels should be closely monitored and supplementation should be provided if necessary, either through oral or intravenous routes. In conclusion, the indications for ESA therapy in CKD are primarily based on the presence and severity of anemia. The dosing strategy for ESAs should be individualized, with careful monitoring and adjustments to avoid complications. By using ESAs appropriately, healthcare providers can improve quality of life, reduce transfusion requirements, and optimize anemia management in CKD patients. Risks, resistance, and adverse effects. Erythropoiesis-stimulating agents, ESAs, are an essential tool in managing anemia in patients with chronic kidney disease, CKD, particularly those on dialysis. While they offer significant benefits in improving hemoglobin levels and quality of life, they are not without risks. Understanding the potential adverse effects, the risk of resistance, and the complications associated with ESA therapy is crucial in ensuring safe and effective treatment for CKD patients. One of the primary risks associated with ESA therapy is the potential for cardiovascular events. As ESAs stimulate the production of red blood cells, they also increase blood viscosity, which can raise the risk of hypertension, stroke, and heart failure, particularly when hemoglobin levels are increased too rapidly or to higher than target levels. Studies have shown that targeting higher hemoglobin levels above the recommended 10 to 11 grams per deciliter range can increase the likelihood of adverse cardiovascular outcomes, leading to increased morbidity and mortality. Therefore, close monitoring of hemoglobin levels is essential, and ESA doses should be adjusted to avoid overly rapid increases in hemoglobin. To minimize cardiovascular risk, healthcare providers aim for a gradual increase in hemoglobin to reach a safe target level. Another significant risk of ESA therapy is iron deficiency. Since ESIs stimulate red blood cell production, they increase the demand for iron. If iron stores are insufficient, the response to ESA therapy can be suboptimal. In such cases, iron supplementation is required to ensure that the body has enough iron for the production of new red blood cells. However, the use of iron supplementation alongside ESAs must be carefully managed to avoid iron overload, which can have its own set of complications, including organ damage and inflammation. Resistance to ESAs is another challenge in the treatment of anemia in CKD. Some patients may not respond adequately to ESA therapy, even when given appropriate doses. This phenomenon, known as ESA resistance, can be caused by several factors, including iron deficiency, inflammation, infections, malnutrition, or poor dialysis adequacy. In some cases, ESA resistance may be linked to increased levels of pro-inflammatory cytokines, which can impair erythropoiesis. Additionally, underlying conditions such as chronic inflammation or infections can exacerbate anemia and reduce the effectiveness of ESAs. Addressing these underlying factors and optimizing iron stores are key to improving the response to ESA therapy. Adverse effects related to ESA therapy also include injection site reactions, such as redness, swelling, or pain at the site of administration. These reactions are typically mild, but can be bothersome for patients. Another concern is the potential for an increase in the risk of malignancy in some patients, as ESAs have been associated with tumor progression in certain cancer patients. While the relationship between ESAs and cancer progression is still being studied, caution is advised when using ESAs in cancer patients, and their use should be carefully considered. In conclusion, while ESAs are an effective treatment for anemia in CKD patients, they come with risks that must be carefully managed. Cardiovascular events, iron deficiency, ESA resistance, and injection site reactions are among the potential complications associated with ESA therapy. Close monitoring of hemoglobin levels, iron status, and the patient's overall clinical condition is essential to minimize risks and ensure the effectiveness of treatment. By addressing these challenges, healthcare providers can help improve patient outcomes and optimize the management of anemia in CKD. Chapter 6: Nutritional and Comorbid Factors. The management of anemia in chronic kidney disease, CKD, extends beyond the use of erythropoiesis-stimulating agents, ESAs, and iron supplementation. Nutritional status and comorbid conditions play a critical role in the development and progression of anemia in CKD patients. These factors influence the effectiveness of treatment, the patient's response to therapy, and the overall prognosis of CKD. Therefore, understanding the impact of nutritional and comorbid factors is essential for optimizing anemia management in this population. Nutritional deficiencies are common in patients with CKD and can contribute significantly to anemia. Protein energy malnutrition, often seen in these patients, can impair erythropoiesis and exacerbate anemia. Adequate intake of proteins, vitamins, and minerals is necessary for maintaining normal red blood cell production. Deficiencies in certain nutrients, such as iron, folate, and vitamin B12, are particularly concerning as they are directly involved in the synthesis of hemoglobin and red blood cell production. For example, iron deficiency impairs the body's ability to produce hemoglobin, while deficiencies in vitamin B12 or folate can hinder the maturation of red blood cells in the bone marrow. In CKD, the kidneys' reduced ability to activate vitamin D contributes to disturbances in calcium and phosphate metabolism, further complicating nutritional status. Secondary hyperparathyroidism, which is common in CKD, may result in bone mineral disorders, affecting overall health and contributing to the development of anemia. Additionally, many CKD patients are on restrictive diets, often limiting the intake of key nutrients, further increasing the risk of nutritional deficiencies. As a result, managing the nutritional status of CKD patients, including ensuring adequate protein and micronutrient intake, is essential in preventing or managing anemia. Comorbid conditions also play a significant role in the development and exacerbation of anemia in CKD. Common comorbidities in CKD patients include diabetes mellitus, hypertension, and cardiovascular disease, all of which can worsen anemia. For instance, chronic inflammation associated with diabetes and hypertension can impair erythropoiesis and contribute to ESA resistance. Inflammation leads to the production of pro-inflammatory cytokines, which suppress the production of erythropoietin and decrease the responsiveness of bone marrow to erythropoiesis-stimulating factors. Additionally, patients with diabetes are at an increased risk of developing iron deficiency due to chronic blood loss, poor gastrointestinal absorption, and altered iron metabolism. The presence of cardiovascular disease is another critical comorbidity that can complicate anemia management. Anemia in CKD has been associated with increased cardiovascular risk, and this relationship is bidirectional. On one hand, anemia exacerbates cardiovascular conditions by reducing oxygen delivery to tissues, increasing the workload on the heart, and potentially leading to heart failure. On the other hand, cardiovascular diseases, such as heart failure, can worsen kidney function, further impairing erythropoiesis and exacerbating anemia. In conclusion, nutritional status and comorbid factors significantly influence the development, progression, and treatment of anemia in CKD patients. Nutritional deficiencies, particularly in iron, vitamin B12, and folate, can contribute to anemia, while comorbidities like diabetes, hypertension, and cardiovascular disease can worsen anemia and complicate treatment. Managing these factors through appropriate nutritional interventions, addressing underlying comorbid conditions, and tailoring anemia treatment to the individual patient's needs is essential for optimizing outcomes in CKD patients. Impact of malnutrition and inflammation. Malnutrition and inflammation are two key factors that significantly impact the progression and management of anemia in patients with chronic kidney disease, CKD. These conditions are often interconnected and contribute to the worsening of anemia, complicating treatment strategies and affecting patient outcomes. Understanding the roles of malnutrition and inflammation is essential for optimizing care and improving the quality of life for CKD patients. Malnutrition is common in CKD patients, especially those in the later stages of the disease, and plays a critical role in the development and severity of anemia. Malnutrition can result from a variety of factors, including dietary restrictions, poor appetite, gastrointestinal issues, and the body's altered ability to process nutrients. Inadequate intake of essential nutrients such as proteins, vitamins, and minerals leads to a decrease in the production of red blood cells and hemoglobin. Protein energy malnutrition, in particular, is a significant risk factor for anemia, as it impairs the synthesis of erythropoiesis-stimulating factors like erythropoietin. Malnutrition also affects the overall immune function, making patients more susceptible to infections that can further exacerbate inflammation and anemia. The relationship between malnutrition and anemia in CKD is also influenced by the body's reduced ability to absorb nutrients, especially in patients with gastrointestinal complications or those on restricted diets. The kidney's diminished function impacts various metabolic processes, which can lead to vitamin deficiencies, such as folate and vitamin B12, both crucial for red blood cell production. Iron deficiency is another common issue in malnourished CKD patients, further impairing the body's ability to produce hemoglobin and leading to exacerbated anemia. Inflammation is a well-known contributor to anemia in CKD and is often referred to as anemia of inflammation. In CKD, inflammation is triggered by various factors, including reduced kidney function, metabolic disturbances, and the accumulation of uremic toxins. Chronic low-grade inflammation leads to the production of pro-inflammatory cytokines such as interleukin-6, IL-6, and tumor necrosis factor alpha, TNF-α, which can inhibit erythropoiesis by suppressing erythropoietin production and disrupting iron metabolism. These cytokines can also impair the bone marrow's ability to produce red blood cells, contributing to a persistent state of anemia in CKD patients. The combined effects of malnutrition and inflammation are particularly detrimental to anemia management in CKD. Inflammatory cytokines reduce the responsiveness of the bone marrow to erythropoiesis-stimulating agents, ESAs, making it more difficult for patients to achieve target hemoglobin levels despite ESA therapy. Additionally, chronic inflammation interferes with iron utilization, contributing to functional iron deficiency, where iron is available in the body but is not effectively used for red blood cell production. This creates a vicious cycle where malnutrition and inflammation exacerbate anemia, making treatment more challenging. In conclusion, both malnutrition and inflammation play a pivotal role in the pathogenesis and management of anemia in CKD. Malnutrition impairs the production of essential nutrients required for red blood cell synthesis, while inflammation disrupts erythropoiesis and iron metabolism. Addressing these factors through nutritional interventions, anti-inflammatory treatments, and close monitoring of iron status is crucial for optimizing anemia management in CKD patients. By managing malnutrition and inflammation effectively, healthcare providers can improve the response to anemia treatment and enhance patient outcomes. Influence of diabetes and cardiovascular disease. Diabetes mellitus and cardiovascular disease, CVD, are two of the most common comorbidities in patients with chronic kidney disease, CKD, and both significantly influence the development and progression of anemia in these patients. These conditions are often intertwined with CKD and exacerbate anemia through various mechanisms, making their management crucial for optimizing patient outcomes. Diabetes is a major risk factor for CKD and has a direct impact on anemia. Chronic hyperglycemia associated with diabetes leads to vascular damage, which can reduce kidney function over time. This damage impairs the kidney's ability to produce erythropoietin, a hormone essential for red blood cell production. As a result, CKD patients with diabetes often experience a reduction in erythropoiesis, contributing to anemia. Additionally, diabetes can cause other complications, such as gastrointestinal issues that impair nutrient absorption, including iron, folate, and vitamin B12, all of which are vital for red blood cell production. Moreover, the chronic inflammatory state associated with diabetes increases the production of pro-inflammatory cytokines, which further suppress erythropoiesis and contribute to the development of anemia. Cardiovascular disease is also closely linked to anemia in CKD patients. Anemia worsens cardiovascular outcomes by reducing oxygen delivery to tissues, increasing the workload on the heart, and exacerbating symptoms of heart failure. In turn, CVD, particularly heart failure, can accelerate the progression of kidney dysfunction and worsen anemia. Heart failure can lead to reduced renal perfusion and glomerular filtration rate, GFR, further impairing the kidney's ability to produce erythropoietin. Additionally, the use of medications commonly prescribed to manage cardiovascular conditions, such as angiotensin-converting enzyme inhibitors or diuretics, can exacerbate anemia by affecting renal function and electrolyte balance. Both diabetes and cardiovascular disease also contribute to inflammation, which further complicates anemia management in CKD patients. Chronic inflammation, often seen in diabetic and cardiovascular patients, disrupts iron metabolism and decreases the responsiveness of the bone marrow to erythropoiesis-stimulating agents, ESAs. This makes it more difficult for patients to achieve optimal hemoglobin levels, even with ESA therapy, and increases the likelihood of iron deficiency despite supplementation. In conclusion, diabetes and cardiovascular disease significantly influence the development and progression of anemia in CKD patients. Diabetes contributes to vascular and kidney damage, as well as inflammation, while cardiovascular disease worsens kidney function and exacerbates the symptoms of anemia. Effective management of both conditions is essential for controlling anemia and improving overall patient outcomes in CKD. Addressing these comorbidities through targeted therapies and close monitoring is crucial in optimizing care and preventing the complications associated with anemia in CKD. Vitamin deficiencies and their role in anemia. Vitamin deficiencies are a common and often overlooked factor contributing to anemia in patients with chronic kidney disease, CKD. Several essential vitamins are necessary for the proper production and maturation of red blood cells, and deficiencies in these vitamins can significantly impair erythropoiesis, leading to anemia. In CKD patients, the kidney's reduced ability to activate certain vitamins, coupled with dietary restrictions and malabsorption issues, increases the risk of deficiencies. Among the most critical vitamins for preventing anemia are vitamin B12, folate, and vitamin D. Vitamin B12 plays an essential role in the production of red blood cells and the synthesis of DNA in the bone marrow. A deficiency in vitamin B12 can lead to megaloblastic anemia, a condition in which the bone marrow produces abnormally large and immature red blood cells. In CKD, vitamin B12 deficiency is common due to decreased dietary intake, impaired absorption, and the use of medications like proton pump inhibitors, which can interfere with vitamin B12 absorption. Additionally, in patients with diabetes or gastrointestinal complications, the risk of vitamin B12 deficiency is increased. Addressing B12 deficiency through supplementation or dietary changes is important for preventing anemia in CKD patients. Folate, another key vitamin involved in red blood cell production, works closely with vitamin B12 to promote proper cell division and maturation in the bone marrow. Folate deficiency can also result in megaloblastic anemia, which can lead to fatigue, weakness, and other symptoms associated with anemia. In CKD, folate deficiency is common, as patients often have inadequate dietary intake or impaired absorption. Additionally, dialysis treatment can remove folate from the body, further exacerbating the deficiency. Ensuring adequate folate levels through dietary sources, oral supplements, or intravenous supplementation in dialysis patients is crucial for effective anemia management. Vitamin D, while primarily known for its role in bone health, is also involved in red blood cell production. In CKD, impaired kidney function reduces the body's ability to activate vitamin D, leading to vitamin D deficiency. This deficiency can contribute to anemia by disrupting calcium and phosphate metabolism, leading to secondary hyperparathyroidism and bone mineral disorders. Additionally, vitamin D deficiency has been linked to increased inflammation, which can further impair erythropoiesis and exacerbate anemia. Correcting vitamin D deficiency in CKD patients may help improve anemia and overall health, particularly in patients undergoing dialysis. In conclusion, vitamin deficiencies, particularly in vitamin B12, folate, and vitamin D, play a significant role in the development and exacerbation of anemia in CKD patients. These deficiencies can impair red blood cell production, disrupt iron metabolism, and contribute to inflammation, making anemia more difficult to manage. Identifying and addressing these deficiencies through supplementation, dietary changes, and close monitoring is crucial for optimizing anemia treatment and improving the overall well-being of CKD patients. Chapter 7: Management Strategies and Guidelines. Effective management of anemia in chronic kidney disease, CKD, requires a comprehensive approach that addresses both the underlying causes and the symptoms of anemia. The management strategies must be tailored to individual patients based on the severity of anemia, the stage of CKD, and the presence of comorbid conditions. This chapter explores the current strategies and guidelines for managing anemia in CKD, including pharmacological treatments, iron supplementation, erythropoiesis-stimulating agents, ESAs, and the role of nutrition. The first line of treatment for anemia in CKD typically involves addressing iron deficiency, which is common in these patients. Iron supplementation can be administered orally or intravenously, depending on the severity of the deficiency and the patient's tolerance to oral iron. Intravenous iron is often preferred in patients with advanced CKD or those on dialysis, as it bypasses the gastrointestinal tract and provides more immediate replenishment of iron stores. Oral iron supplementation can be effective in mild to moderate iron deficiency, but may cause gastrointestinal side effects, limiting patient compliance. Erythropoiesis-stimulating agents, ESAs, are another cornerstone of anemia management in CKD. These agents stimulate the production of red blood cells by mimicking the action of erythropoietin, a hormone produced by the kidneys. The use of ESAs has significantly improved the quality of life for CKD patients by reducing the need for blood transfusions and alleviating the symptoms of anemia. However, the use of ESAs must be carefully monitored to avoid complications such as hypertension, thrombosis, and stroke. The goal is to maintain a target hemoglobin level that alleviates symptoms without posing undue risks. Recent guidelines recommend tailoring ESA doses based on hemoglobin levels, with a goal of maintaining levels between 10 to 11 g/L, although individual patient needs may vary. In addition to pharmacological treatments, nutritional management plays a key role in anemia management. Ensuring adequate intake of nutrients such as iron, vitamin B12, folate, and vitamin D is essential for supporting optimal red blood cell production. Dietary adjustments, along with supplementation where necessary, can help prevent deficiencies that exacerbate anemia. In patients with severe malnutrition, nutritional support may be required to improve overall health and promote better responses to anemia treatment. Management strategies also focus on controlling underlying comorbid conditions, particularly diabetes, hypertension, and cardiovascular disease. These conditions can worsen anemia by increasing inflammation, impairing erythropoiesis, and reducing the responsiveness to ESA therapy. Tight control of blood glucose, blood pressure, and lipid levels is essential to minimize their impact on anemia and improve kidney function. For example, angiotensin-converting enzyme inhibitors, ACE inhibitors, and angiotensin receptor blockers, ARBs, are commonly used to manage hypertension and protect kidney function, which in turn helps prevent or reduce the severity of anemia. In conclusion, the management of anemia in CKD requires a multifaceted approach that includes pharmacological treatments, nutritional support, and control of comorbid conditions. Current guidelines emphasize a personalized approach with close monitoring of hemoglobin levels, iron status, and ESA use to ensure optimal outcomes. By addressing the root causes of anemia and utilizing appropriate therapies, healthcare providers can significantly improve the quality of life for CKD patients and help prevent the progression of kidney disease. Current clinical guidelines, KDIGO, KDOQI. The management of anemia in chronic kidney disease, CKD, is guided by several established clinical guidelines, including those from the Kidney Disease Improving Global Outcomes, KDIGO, and the Kidney Disease Outcomes Quality Initiative, KDOQI. These guidelines provide evidence-based recommendations for the diagnosis, treatment, and management of anemia in CKD patients, helping healthcare providers optimize care and improve patient outcomes. The KDIGO guidelines, which are widely followed in clinical practice, emphasize the importance of early detection and intervention for anemia in CKD. According to KDIGO, anemia should be diagnosed based on hemoglobin levels, with a threshold of less than 13 g/Dl for men and 12 g/Dl for women. However, the guidelines also note that individual patient factors, including age, sex, and comorbid conditions, may influence the interpretation of hemoglobin levels. KDIGO recommends the assessment of iron status, including ferritin and transferrin saturation, TSAT-T, to identify iron deficiency as a potential contributing factor to anemia. The guidelines also highlight the importance of addressing underlying causes of anemia, such as malnutrition, inflammation, and vitamin deficiencies. For treatment, KDIGO advises a stepwise approach that includes the use of iron supplementation and erythropoiesis-stimulating agents, ESAs, when necessary. In patients with iron deficiency, oral or intravenous iron should be administered to restore iron stores. The choice between oral and intravenous iron depends on the severity of deficiency and patient factors such as dialysis status and gastrointestinal tolerance. KDIGO also recommends the use of ESAs for patients with hemoglobin levels less than 10 grams per liter, particularly in those with CKD stages 3-5, to reduce the need for blood transfusions and improve symptoms. However, the guidelines stress the importance of closely monitoring ESA use to avoid complications such as hypertension, thromboembolism, and stroke. Similarly, the KDOQI guidelines, developed by the National Kidney Foundation, provide comprehensive recommendations for managing anemia in CKD. The KDOQI guidelines align closely with the KDIGO recommendations, but also emphasize the importance of individualized care. KDOQI highlights that the goal of anemia treatment should be to achieve a hemoglobin level that improves quality of life and reduces symptoms without increasing the risks associated with overcorrection. The guidelines recommend a target hemoglobin level of 11 to 12 Gs per dL, although they acknowledge that individual patient characteristics may warrant adjustments. KDOQI also places a strong emphasis on managing comorbid conditions, including diabetes, hypertension, and cardiovascular disease, which can worsen anemia and complicate treatment. Both KDIGO and KDOQI guidelines recommend regular monitoring of hemoglobin levels, iron status, and ESA dosing to ensure appropriate management of anemia in CKD patients. These guidelines are continuously updated to reflect new research and clinical findings, ensuring that healthcare providers have access to the most current and evidence-based recommendations for optimal care. In conclusion, the KDIGO and KDOQI guidelines provide essential frameworks for managing anemia in CKD, focusing on early detection, individualized treatment, and regular monitoring. By adhering to these guidelines, healthcare providers can better manage anemia in CKD patients, improving outcomes and enhancing the quality of life for those affected by this condition. Integrated management approach. An integrated management approach for anemia and chronic kidney disease, CKD, combines multiple therapeutic strategies to address the complex nature of both anemia and CKD. This holistic approach recognizes that anemia in CKD is not a singular condition, but a multifactorial issue, often influenced by factors such as iron deficiency, erythropoietin insufficiency, chronic inflammation, and comorbidities like diabetes and cardiovascular disease. The goal is to create a comprehensive care plan that targets the underlying causes of anemia while also managing CKD and improving overall patient outcomes. The first critical component of an integrated management approach is the thorough evaluation of the patient's clinical status. This includes a detailed assessment of kidney function, hemoglobin levels, iron stores, and the presence of other factors like vitamin deficiencies or inflammation. By evaluating these factors, healthcare providers can determine the specific cause of anemia and tailor the treatment plan accordingly. For instance, if iron deficiency is identified, intravenous or oral iron supplementation can be used to restore iron levels. If erythropoietin production is inadequate, erythropoiesis-stimulating agents, ESAs, may be considered to stimulate red blood cell production. The management strategy must also consider comorbid conditions that exacerbate both CKD and anemia. Conditions like diabetes and cardiovascular disease can worsen kidney function and interfere with the body's ability to manage anemia effectively. Therefore, An integrated approach involves the management of these comorbidities to prevent the progression of both CKD and anemia. Tight blood sugar control in diabetic patients, optimal blood pressure management, and careful management of cholesterol levels are essential components of a holistic care plan. In addition to pharmacological treatment, nutrition plays a vital role in managing anemia. Ensuring that patients receive adequate nutrients such as iron, folate, vitamin B12, and vitamin D is essential for supporting healthy red blood cell production. In CKD, dietary restrictions can make it challenging to maintain proper nutrition, so nutritional counseling and supplementation may be necessary to address any deficiencies. An integrated approach to care also involves close monitoring of these nutritional levels and adjusting the treatment plan as needed. Another key aspect of the integrated management of anemia in CKD is patient education and involvement in their care. Ensuring that patients understand the importance of medication adherence, dietary modifications, and regular monitoring can help improve treatment outcomes. Engaging patients in shared decision-making also allows for personalized treatment that considers their preferences and lifestyle, ultimately leading to better compliance and improved quality of life. Finally, regular follow-up care is essential for monitoring the patient's response to treatment and making necessary adjustments. This includes monitoring hemoglobin levels, iron status, and kidney function, as well as assessing any side effects from treatments, such as ESAs or iron supplementation. In conclusion, an integrated management approach for anemia in CKD combines comprehensive clinical evaluation, pharmacological treatment, management of comorbid conditions, nutritional support, patient education, and ongoing monitoring. This holistic approach ensures that all factors contributing to anemia are addressed, providing CKD the best possible chance for optimal health and well-being. Monitoring and treatment targets. Monitoring and treatment targets play a critical role in the management of anemia and chronic kidney disease, CKD. Given the multifactorial nature of anemia and CKD, establishing appropriate monitoring strategies and treatment goals is essential to ensure optimal care and improve patient outcomes. By tracking key biomarkers and adhering to evidence-based guidelines, healthcare providers can tailor interventions to address both the underlying causes of anemia and the specific needs of the patient. The primary goal of treatment in CKD-associated anemia is to improve symptoms, prevent complications, and enhance the patient's quality of life. One of the most important aspects of monitoring is the regular assessment of hemoglobin levels. The target hemoglobin range varies depending on the stage of CKD and the specific treatment plan, but generally, the goal is to maintain hemoglobin levels between 10 and 11 grams per deciliters. This target range helps to alleviate the symptoms of anemia, such as fatigue and weakness, without increasing the risk of complications like cardiovascular events or stroke, which can occur if hemoglobin levels are too high. In addition to hemoglobin levels, iron status is a critical marker for monitoring anemia treatment in CKD patients. The two main indicators for iron deficiency are ferritin and transferrin saturation, TSAT. Ferritin reflects the body's iron stores, while TSAT measures the proportion of transferrin, the protein that transports iron that is bound to iron. According to guidelines, a ferritin level of less than 100 engrams per milliliters or a TSAT below 20% indicates iron deficiency. Regular monitoring of these parameters allows healthcare providers to adjust iron supplementation either through oral or intravenous routes to optimize iron levels and prevent iron overload or deficiency. Another important aspect of monitoring is the assessment of erythropoiesis-stimulating agents, ESAs. These agents are commonly used in CKD to stimulate red blood cell production when erythropoietin levels are insufficient. Monitoring ESA dosing and patient response is crucial, as overuse can lead to adverse outcomes, such as hypertension, thrombosis, or stroke. Current guidelines recommend targeting a hemoglobin level of 10 to 11 grams per deciliters, and adjustments to ESA therapy should be made to maintain this range. ESA should be used at the lowest effective dose to minimize risks. Furthermore, it is essential to monitor the progression of CKD itself. Kidney function is typically tracked through glomerular filtration rate, GFR, and early intervention can help slow the progression of both CKD and associated anemia. Blood pressure control, management of diabetes, and addressing other comorbid conditions can significantly impact the course of CKD and its related anemia. Lastly, monitoring for potential side effects and complications of treatment is crucial. Patients receiving iron supplements, ESAs, or other medications should be monitored for signs of adverse effects, such as iron overload, elevated blood pressure, or vascular events. Close surveillance through regular laboratory testing, clinical evaluation, and patient reports of symptoms ensures that interventions remain safe and effective. In conclusion, monitoring and treatment targets are vital in managing anemia in CKD patients. Regular assessment of hemoglobin levels, iron status, and ESA dosing, combined with careful monitoring of kidney function and treatment side effects, enables healthcare providers to deliver personalized, effective care. Achieving appropriate treatment targets ensures the improvement of anemia symptoms, the prevention of complications, and the overall enhancement of patient well-being. Chapter 8, Special Populations and Future Directions. Anemia and chronic kidney disease, CKD, affects a diverse range of patient populations, each with unique challenges and considerations. Understanding the needs of these special populations is critical to tailoring effective treatment plans and improving outcomes. As the landscape of CKD treatment continues to evolve, future directions in anemia management focus on addressing the gaps in care, refining therapeutic strategies, and personalizing approaches for patients with specific conditions, including the elderly, pediatric patients, pregnant women, and those with concurrent comorbidities. One special population that requires careful attention is the elderly. Aging brings about a natural decline in kidney function, and older adults are often more susceptible to both anemia and CKD. This group frequently has multiple comorbidities, such as cardiovascular disease, diabetes, and hypertension, which complicate both the diagnosis and treatment of anemia. Furthermore, age-related changes in bone marrow function and erythropoiesis make it more challenging to manage anemia effectively. In these patients, a more cautious approach to erythropoiesis-stimulating agents, ESAs, and iron supplementation may be necessary, as they are more vulnerable to the risks of cardiovascular events and iron overload. Close monitoring and individualized treatment plans are essential to ensure optimal outcomes. Pediatric patients with CKD present a unique challenge in the management of anemia due to their developing physiology. Children with CKD are at risk for growth retardation, developmental delays, and other complications related to anemia. Treatment must balance the need to address anemia with the consideration of long-term growth and development. Pediatric patients may require more frequent adjustments in therapy as their bodies change rapidly. As with elderly patients, ESAs and iron therapy need to be carefully monitored and dosed to avoid complications like iron overload or excessive erythropoiesis. Pregnant women with CKD also represent a special population requiring careful management of anemia. Pregnancy itself can lead to physiological changes that exacerbate anemia, and CKD complicates the picture further. Anemia in pregnancy is typically due to a combination of increased blood volume, iron deficiency, and sometimes inadequate erythropoietin production. The management of anemia in pregnant women with CKD needs to consider both maternal and fetal health. Iron supplementation, erythropoiesis-stimulating agents, and careful monitoring of kidney function are crucial to avoid adverse outcomes such as preterm birth, low birth weight, or maternal complications. Patients with comorbid conditions, such as diabetes, cardiovascular disease, or malignancy, require integrated care to address the overlapping factors contributing to anemia. In these patients, managing anemia is often intertwined with managing the underlying disease processes. Comorbidities can complicate both the cause and the treatment of anemia, requiring a multidisciplinary approach to ensure that all aspects of the patient's health are addressed simultaneously. Looking to the future, advancements in personalized medicine and biotechnology hold the potential to significantly improve the management of anemia in CKD. Innovations in genetic testing, new drugs targeting specific pathways involved in anemia, and the development of novel erythropoiesis-stimulating agents could provide more targeted and effective treatments with fewer side effects. Furthermore, as our understanding of the molecular mechanisms underlying anemia in CKD deepens, more precise treatments may emerge, allowing healthcare providers to better tailor therapies to individual patients based on their unique genetic and clinical profiles. In conclusion, managing anemia in CKD in special populations requires a nuanced, patient-centered approach. The future of anemia management lies in personalized, targeted therapies that take into account the diverse needs of individuals, particularly those in vulnerable or high-risk groups. Continued research and advancements in technology will undoubtedly improve outcomes and help ensure that anemia management becomes more effective and accessible for all patients, regardless of their age, pregnancy status, or comorbid conditions. Anemia in dialysis versus non-dialysis patients. Anemia is a common and significant complication of chronic kidney disease, CKD, with its severity often increasing as the disease progresses. However, the management of anemia in patients with CKD differs notably between those who are on dialysis and those who are not. The pathophysiology, treatment strategies, and outcomes for anemia in these two groups are influenced by factors related to kidney function, the need for renal replacement therapy, and the presence of other comorbidities. In dialysis patients, anemia is primarily driven by a combination of decreased erythropoietin production, iron deficiency, and the loss of blood during dialysis treatments. The kidneys produce erythropoietin, a hormone essential for stimulating red blood cell production in the bone marrow. In advanced CKD, as kidney function declines, erythropoietin production is reduced, leading to a decrease in red blood cell production and the development of anemia. Dialysis itself can exacerbate anemia, as blood loss during the procedure, along with the need for frequent access to the vascular system, can further deplete red blood cell counts. Iron deficiency is also common in dialysis patients due to increased losses and impaired iron utilization, making iron supplementation an essential part of their anemia management. In contrast, non-dialysis patients with CKD experience anemia primarily due to reduced erythropoietin production, although iron deficiency is still a significant contributing factor. However, non-dialysis patients typically do not suffer from the same degree of blood loss as dialysis patients. Therefore, their anemia may not be as severe in the earlier stages of CKD. Treatment in non-dialysis patients often focuses on correcting iron deficiency and stimulating erythropoiesis through erythropoiesis-stimulating agents, ESAs, when necessary. The goal in these patients is to manage kidney disease progression while addressing anemia through appropriate iron supplementation and, in some cases, ESAs. One key difference between the two groups is the approach to erythropoiesis-stimulating agents. In dialysis patients, ESAs are frequently used to maintain hemoglobin levels within the target range. However, in non-dialysis patients, the use of ESAs is typically reserved for more advanced stages of CKD or when anemia is symptomatic. Additionally, dialysis patients require more careful monitoring of ESA therapy, as the risk of adverse effects, such as hypertension and thrombosis, is higher in this population. In conclusion, while anemia is prevalent in both dialysis and non-dialysis patients with CKD, the underlying causes and treatment strategies differ. Dialysis patients face additional challenges, including blood loss and the need for more frequent iron and ESA management. Non-dialysis patients, on the other hand, typically experience less severe anemia but still require careful attention to erythropoietin production and iron status. Tailoring treatment to the specific needs of these groups is essential for optimal care and improved patient outcomes. Pediatric and elderly considerations. Managing anemia in patients with chronic kidney disease, CKD, presents unique challenges in both pediatric and elderly populations. These two age groups require specialized attention due to their distinct physiological differences, comorbidities, and treatment responses. Understanding these considerations is crucial to developing effective and personalized anemia management strategies for both children and older adults. In pediatric patients with CKD, anemia can have profound effects on growth, development, and overall quality of life. The young body's metabolic demands are high, and anemia can interfere with normal growth and cognitive development, making early detection and treatment essential. Pediatric patients may have a more aggressive disease course compared to adults, and the underlying causes of anemia can vary depending on the stage of kidney disease. In children, iron deficiency, erythropoietin deficiency, and inflammation can all contribute to anemia. Treatment strategies must be carefully adjusted to account for the child's developmental needs. For instance, erythropoiesis-stimulating agents, ESAs, must be administered with caution to avoid rapid increases in hemoglobin that could pose risks such as hypertension or seizures. Iron supplementation is often required, but the dosage must be adjusted based on the child's growth and iron absorption capabilities. Monitoring is especially important in children to ensure that anemia treatment does not interfere with their overall growth and developmental milestones. In elderly patients, anemia in CKD is often compounded by the presence of multiple comorbidities, such as cardiovascular disease, diabetes, and hypertension. Aging also affects kidney function, and older adults may have more difficulty tolerating both the symptoms of anemia and the treatments. The elderly population is at increased risk for adverse effects from anemia treatments, including erythropoiesis-stimulating agents and iron supplementation, as these can exacerbate existing cardiovascular issues or lead to iron overload. Additionally, elderly patients are more likely to have age-related changes in bone marrow function, which can reduce the effectiveness of ESA therapy. In managing anemia in elderly patients, healthcare providers must balance the benefits of improving anemia-related symptoms with the risks associated with treatment. A conservative approach to ESA dosing is often recommended, and iron supplementation must be carefully monitored to prevent complications like iron overload. In conclusion, pediatric and elderly patients with CKD present unique challenges in anemia management. In children, the focus must be on supporting growth and development while effectively managing anemia, often with careful monitoring of ESA and iron therapy. In elderly patients, the emphasis is on minimizing treatment risks and addressing comorbidities that could complicate anemia treatment. A tailored, age-specific approach is essential for optimizing outcomes in both populations. Emerging therapies and research trends. The management of anemia in chronic kidney disease, CKD, is evolving, with new therapies and research trends offering promising alternatives to traditional treatment options. As the understanding of the underlying mechanisms of anemia in CKD deepens, novel approaches are emerging that aim to improve outcomes for patients by addressing the root causes of anemia more effectively. One of the most significant areas of research focuses on the development of novel erythropoiesis-stimulating agents, ESAs, and their mechanisms of action. Traditional ESAs stimulate red blood cell production by mimicking erythropoietin, but emerging agents are exploring ways to enhance erythropoiesis in a more targeted and efficient manner, potentially reducing the risks of adverse effects like hypertension and thrombosis. These next-generation ESAs aim to improve hemoglobin levels without the complications associated with current treatments. Additionally, agents that not only stimulate erythropoiesis but also target other factors contributing to anemia, such as inflammation or iron metabolism, are being actively investigated. Another promising research direction is the use of hypoxia-inducible factor, F, stabilizers. HIF stabilizers work by mimicking low oxygen conditions in the body, which triggers the natural production of erythropoietin. These agents have shown potential in stimulating red blood cell production with a lower risk of hypertension and cardiovascular events compared to traditional ESAs. Currently, several CHIF stabilizers are in clinical trials with encouraging results that may offer a new class of drugs for anemia management in CKD. Iron homeostasis continues to be a focus of emerging research, particularly in developing therapies that address functional iron deficiency. While traditional iron supplementation can effectively raise iron levels, many CKD patients still experience anemia due to impaired iron utilization. New iron formulations, such as ferric carboxymaltose, are being explored to improve iron delivery and absorption, potentially offering more effective solutions for patients who do not respond well to standard iron therapies. In addition to drug-based therapies, research is also investigating non-pharmacological approaches to anemia management. These include the potential benefits of dietary interventions, such as the use of iron-rich foods or supplements that enhance iron absorption, and the role of the microbiome in influencing anemia and CKD progression. In conclusion, the future of anemia treatment in CKD holds significant promise, driven by advancements in drug development, iron therapy, and our understanding of the disease. The emerging therapies and research trends in this area have the potential to revolutionize anemia management, offering patients more effective and safer options to improve their quality of life. Conclusion: anemia and chronic kidney disease, CKD, remains a complex and multifaceted issue that significantly impacts patient outcomes. The relationship between anemia and kidney disease is intricate, with multiple factors such as reduced erythropoietin production, iron deficiency, inflammation, and uremic toxins contributing to its development and progression. Addressing anemia in CKD requires a comprehensive understanding of these mechanisms and a tailored treatment approach that considers the patient's individual needs. Effective management of anemia in CKD, whether in dialysis or non-dialysis patients, involves a combination of erythropoiesis-stimulating agents, iron supplementation, and careful monitoring of kidney function and comorbid conditions. While treatment goals generally aim to alleviate symptoms and improve quality of life, ongoing research into emerging therapies, such as HIF stabilizers and next-generation ESAs, holds the potential to provide more effective and safer options for patients in the future. Special populations, including pediatric and elderly patients, present unique challenges in anemia management. For children, ensuring proper growth and development while treating anemia is a primary concern, while in the elderly, managing comorbidities and avoiding treatment-related complications is crucial. Understanding these considerations is vital for optimizing care in these diverse groups. The future of anemia management in CKD looks promising with ongoing research and advancements in therapy. As our understanding of the disease deepens, more personalized and effective treatments will emerge, improving patient outcomes and quality of life. By continuing to explore new treatment options, refining current approaches, and prioritizing patient-centered care, healthcare providers can offer better solutions for managing anemia in CKD, ultimately improving the overall prognosis for patients living with this condition.